Good afternoon, everyone. My name is Rafael Alonso, and I want to thank the organizers for inviting me to be here today to talk about drivers of heart failure and congenital heart disease. I don't have any conflict of interest to declare. In the next 15 minutes, I will try to discuss the importance of heart failure in patients with congenital heart disease. We'll go through the mechanisms of heart failure in this population, and we will discuss some of the future directions in heart failure in patients with congenital heart disease. Over the last 50 years, if anything we have done well is probably due to the improvement in the surgical techniques and the ICU care, as well as our understanding of the condition and the different congenital heart disease, is improving the survival of patients born with congenital heart disease, to the point that nowadays the number of adults with congenital heart disease is more than double than pediatric patients with congenital heart disease. And we have shifted the mortality from the early decades to the 6th or 7th decade of life. But we have learned as well that as our population gets older, the prevalence of heart failure also increases. And recent data have shown that after 40 years, heart failure becomes the main cause of death of this population. These are data that from the Brompton, when I was in London, where we look at our heart failure admissions over the whole population of congenital heart disease over a period of 12 years. The different colors represent different age groups, and the yellow is the group with more than 50 years old. On the left side, you can see patients that were admitted at least twice over the last 2 years. On the right-hand side, you see patients that were admitted at least 4 times for heart failure over the last 2 years. As you can see, over time, the admissions for heart failure increased in all age ranges, but the increase was exponentially in patients over 50 years old. Why this is important is because in patients with congenital heart disease, as happened with patients with acquired heart disease, heart failure increases mortality. But what is interesting in this population is that the mortality risk remains after being admitted for heart failure. So on the right-hand side, in this panel, this data from Montreal represent the mortality risk of patients with congenital heart disease after having an admission for heart failure. As you can see, after the admission, the risk reduces over time, but after 2 or 3 years, the risk of death plateau and remains around 4 times higher than congenital heart disease patients with no heart failure. But one of the major challenges that we have in congenital heart disease patients with heart failure is to determine when they are at risk of developing heart failure. If we look at the latest universal definition of heart failure that was published in JACC in June this year, you can see that every patient with a structural heart disease should be considered as patients with pre-heart failure or stage B. If we use this definition, patients with congenital heart disease are at risk of developing heart failure already at birth because they are born with a congenital heart disease, with a structural heart disease. In fact, many of these patients will develop heart failure at birth. We will fix them normally with an operation. They will go back to their baseline, which is never is going to be equal to our patients with a normal heart. They will have another declines during their lives that we will probably do several interventions, fix them until they hit the point that they are included in a transplant list. And as you know, these patients wait longer on the transplant list and they have a higher mortality. But if I have to choose one challenge in congenital heart disease, heart failure, is how to establish the diagnosis in these patients. As we have said, patients with congenital heart disease are used to have limited exercise capacity and they adapt their activity to their limitations. Sometimes it's challenges to determine their functional class because they are used to be limited and they don't think they are limited. But it's very common that they present with atypical symptoms like fatigability, they have ascites, or they have lack of concentration. It's not usual to present with diarrhea, symptoms that the majority of acquired heart disease patients would not lead to the diagnosis of heart failure. So it is important to be aware of these symptoms and to be well trained in identify them, not to miss a heart failure diagnosis in this population. But when we look at the mechanisms of heart failure, of course, it's obvious that we have a phenotype that is the main problem of these patients. They are born with an abnormal heart and with an structural heart disease that some of them are going to lead to heart failure. But one of the major differences between the phenotype of congenital heart disease patients and phenotype of patients with acquired heart disease is that our population is very heterogeneous. So we are dealing with patients that present to us with unrepaired defects, patients that have a prior repair or even a prior palliation, that are left with residual volume or pressure overload lesions, like systemic RV would be an example of a pressure load lesion, whereas a severe pulmonary regurgitation would be an example of a volume load lesion. And they might have a systemic RV, they might have a single ventricle. And these residual lesions, majority of them or many of them gonna be valve disease that's gonna lead to ventricular failure, gonna lead to a single ventricle failure, systemic right ventricle failure, which is unique in congenital heart disease, or more common than in the acquired heart disease population, many of our patients will have a isolated right heart failure. Of course, there are a lot of factors that gonna trigger the developing of heart failure in this population, as of course arrhythmias, but unique to congenital heart disease patients is cyanosis. Cyanosis will increase myocardial fibrosis. Cyanosis is also one of the risk factors to develop restrictive right ventricle. Some of our patients have something also almost unique to the congenital heart disease patient, which is endocardial fibroelastosis, and they have a higher prevalence of endothelial dysfunction, a higher prevalence of pulmonary hypertension. As we said, we have done a very good job making these people to grow older. And of course, now they present with acquired conditions as hypertension, diabetes, obesity, conditions that we know that are risk factors for developing heart failure in acquired heart disease patients. So the combination of all of this is gonna lead to a heart failure syndrome that we're gonna have to deal with it. And one of the major differences between acquired heart disease and congenital heart disease heart failure is how we deal with that first presentation of heart failure. Whereas in acquired heart disease, as all of us know, our first target is to modify that neurohormonal cascade and give them medications to try to control that heart failure and improve their outcome. In congenital heart disease, it's very common that first presentation of heart failure probably is going to lead to some kind of intervention, either in the cath lab or in the OR, but some kind of intervention. And medical therapy in this population, as you know, is not that we don't have as much evidence of as we have in acquired heart disease, and their use come later in the pyramid of treatment. If anything has really advanced in acquired heart disease over the last years, our knowledge of how much genetics affects or can explain the developing of heart failure in acquired heart disease. Unfortunately, this has not been the case in patients with congenital heart disease, and genetic conditions only can explain heart failure in around 5 to 10% of our population. And these are limited to patients with specific syndromes, like patients with Noonan syndrome, that from the congenital perspective, the majority of them, they will present with pulmonary stenosis, and they have a higher risk of developing hypertrophic cardiomyopathy, and 25% of them die for heart failure in the first year of life. The Williams syndrome, which from the congenital perspective, they will present with supravalvular aortic stenosis, and up to 7% of them will develop heart failure at some point in life. And the most common patient, or the largest group that we deal with, is the patients with 20q11 deletion, or the George syndrome, patients that present normally with conotruncal abnormalities, and they will develop heart failure because normally a right-sided problem, either because they have a residual lesion with a volume load ventricle, or very common, they have a high risk of restrictive right ventricle. But the interesting part, and probably the most interesting pathway for this follow, is that the phenotype and genetics alone will not, probably do not explain all the cases of heart failure in patients with congenital heart disease. And probably we can hypothesize that there are some genetics conditions that cause congenital heart disease, and at the same time, they're going to predispose to develop heart failure in patients that have a specific hemodynamic stress, named overload, a pressure overload ventricle or a volume overload ventricle. This pre-genetic condition in the specific, with this pre-genetic condition, with this specific trigger, is going to lead to a reactivation of the fetal genes that are in mutated pathways in the setting of congenital heart disease. And this might be a good pathway to explore to understand better congenital heart disease heart failure. In a recent study, these authors, they look at 146 genes that we know that involve in congenital heart disease, either in humans or in animal models. And they identify in that these genes are linked to several pathways that are recognized pathways that responsible to develop heart failure. So probably this is a good starting point to approach or to lead our research to have a better understanding of heart failure in congenital heart disease. I see this like an opportunity where we can use the current different techniques that we have, and we might see in the future more genes that are, we might identify more genes related with a specific congenital heart disease. And if we link these genes to pathways that lead to heart failure, that will lead to a better understanding of our patients. And just to finalize, if I have to put a single thought on what it would be my dream future, this is something that, this is a very interesting paper written by Adrienne Marali from Montreal, where she has this idea, which I really share, that ideally what we would like to have in the future in our patients is to have a patient with a phenotype. So we know exactly what lesion we patient have. We will understand the genomics of that patient. So we will have all the genetics information in all congenital heart disease patients, and in a specific environment, the combination of these three factors, with the help probably of AI, is gonna let us to have what she coined a custom, which is basically to have an individualized approach to our patients in terms of diagnosis and management. So diagnosis, risk of developing certain conditions, in this case, developing heart failure, and hopefully a future direction of either preventing the developing of heart failure or even managing the condition in the future. And with this, I just want to finish here, and thank you very much. I'm happy to take any questions.